I'd like to introduce our first speaker for the night, and then we'll try to open up some windows and stuff here too to help cool the place off this evening. Our first speaker is Dr. Harry Adelson. He has performed nearly 5,000 bone marrow and adipose-derived adult stem cell procedures, placing him among the most experienced in the world with the use of autologous stem cells for the treatment of musculoskeletal pain conditions. In 2016, Dr. Adelson became the stem cell doctor to Dave Asprey, who some of you here may know. As he puts it, after 20 years of working my fingers to the bone, I became an overnight success. He is the founder of the Dorsaire Clinics and practices in Park City, Utah. If I butchered that pronunciation, please correct me when they go. So please welcome Dr. Harry Adelson.
Thank you very much, you guys. So when I was younger, I was completely fanatical about rock climbing. My entire life revolved around rock climbing. Really, the reason I went to naturopathic school was so I'd have something to do when I wasn't rock climbing. And I was training, I was wrapping up my first year of naturopathic school in Portland, Oregon, and I was training for a dream trip to France, the birthplace of modern sport climbing. And I felt this, I was in the gym and I was doing this hard move and I felt this grotesque pop in my shoulder. And I just thought, oh man, that's not good. And saw a surgeon, and he, had an MRI, and I was told I had a piece of torn cartilage in my shoulder. And really, I tried naturopathic medicine to what we were learning at school to treat it, and really nothing would touch it. It was really very painful. And I saw a surgeon, and he said, well, I can put a scope in there, and I can cut away that piece of cartilage. It's going to help you in the short term, but it's probably going to give you problems later in life. And I just was not willing to take no for an answer. I mean, it just didn't make sense to me. I mean, here I was at the time, I was in my early 20s, I was extremely healthy, I was in naturopathic school, and the guiding principles of naturopathic medicine is using the body's ability to heal itself. And really, that's another way to say biohacking. Now, back then, this was in the early to mid 1990s, we didn't have the term biohacking. I'm not even sure we had the term hacking at that point. But I knew that there had to be a way that I should be able to jumpstart my body's ability to heal itself after injury. I was introduced to this man, Rick Marinelli, who was the first naturopathic doctor to do prolotherapy, regenerative injection therapy. And he treated me with prolotherapy, and it resulted in a complete cure. And from that experience, that's really what set me on this path. And my, sort of my life path unfolded before me. And by the way, my trip to France was splendid. So I'll tell you a little bit about prolotherapy and regenerative injection therapy. I was talking to a doctor here who's a prolotherapist, just to give you a little bit of background, because stem cell therapy really is the natural evolution of prolotherapy. The basic premise behind prolotherapy is this whole concept between macroscopic pain generators and microscopic pain generators. So a macroscopic pain generator would be like you have a broken bone, and you take an x-ray of that broken bone, and that's the problem. You have a broken bone. The thing is, most pain generators, people living with chronic pain, what you see on the imaging actually isn't the problem. If you do MRIs of 100 people with no low back pain, people who never had low back pain, and you do an MRI on them, 60% of them are going to have abnormalities on their MRI. 15% of them are going to have abnormalities so significant that if they had corresponding symptoms, which they don't, they would be candidates for immediate emergency surgery. Similarly, when you take people with lots of back pain, especially neck pain, frequently they have perfectly normal looking MRIs. So what does that tell us? The American College of Physicians, which is the granddaddy of all medical organizations, has put out, in 2011, they put out a position paper which said, stop ordering MRIs for people with back pain. If somebody has a neurologic deficit, so they've got drop foot, they've got loss of fecal continence, okay, that's a good time to order an MRI. If you suspect cancer, that's a good time to order an MRI. Shy of that, they're really just for not what we call non-specific low back pain. The only thing you're achieving by ordering an MRI is you're sending somebody down some very expensive and potentially dangerous rabbit holes. The only thing we know for sure that ordering an MRI is going to do, it's going to increase the cost of whatever that person's treatment is. And that's really it. It does not help the outcomes at all. So what does that tell us? I mean, that tells us that what it is that we see in the images probably isn't even the problem, that it probably isn't the pain generator. So that shifts our focus to the microscopic level. So the two main things that we're looking at the microscopic level, one is the collagen matrix. So, our connective tissue is a miracle fabric. It stretches just the right amount in each direction. When it's stretching, the nerves that pass through it, the sensory nerves, pass freely through it. It doesn't get caught up. You're not firing pain signals every time you move your arm because those fascial planes are just move freely, just the right amount. Well, when you have what we call suboptimal healing, so you have an injury, you go through a healing phase, and you don't completely heal. You have changes in the microscopic anatomy. What ends up happening is your miracle fabric then loses its miracle properties. It stretches too much in some directions and not enough in others. And more importantly, those sensory nerve fibers that pass through it don't pass freely through it. They get caught up, they get snagged, and they fire pain signals with movement. The other thing that happens on the microscopic level is what's called neovascularization. And neovascularization is the hyperconcentration of irregularly formed blood vessels. And this is something that we've known about for a long time that occurs. When you have injury, when you have an injured area, it tends to trigger the growth of irregularly shaped blood vessels. We don't know exactly why this is. We used to think that it was the body's attempt to bring more blood bring more blood flow to the area, but these are irregularly shaped. So instead of efficiently bringing oxygen to the area and bringing metabolic waste away, you actually lose that ability. You actually are having difficulty getting oxygen to the area and getting metabolic waste away. The other problem with neovascularization is every time you grow a new blood vessel, you also grow a new sensory nerve along next to it. And so now you have a hyperconcentration of sensory nerves. Now, this neovascularization, we've known for a long time we've known that that's what happens in tendinitis, like tennis elbow, golf elbow, something like that. But what we've learned in recent years is this happens in arthritis. When you have a degeneration of an articulation, you actually get these irregular shaped blood vessels in the joint. So that also happens in the spinal canal. When people have spinal abnormalities, you're actually having this loss of the ability to bring oxygen to the area, nutrients to the area, metabolic waste such as carbon dioxide away from the area. So when we look at this concept of these microscopic beds of connective tissue being the pain generator, what that does is it sort of shifts the whole concept of what our approach is as a doctor. In conventional pain management, in orthopedic surgery, we look at the body, those guys look at the body like an engine comprised of individual parts, and the way you determine which part needs to be replaced or repaired is by looking at the MRI. And part of that is because that's how our medical system is based. With third payer, with insurance medicine, you have to justify, like, you're my patient, but you're not my client. The insurance company is my client, and you're just sort of this commodity, and I have to justify to the insurance company why it is I'm doing something, and they want objective evidence, like an MRI. So I have to be able to say, this is the reason that I'm treating that, even though we know there's all this data to show that might have nothing to do with what's causing your pain. So, I mean, it really just, unfortunately, that is what directs so much of clinical decision-making in conventional care. We use the MRI to dictate to us which part needs replacing or repairing. Whereas in a regenerative medicine, the field that I'm in, we view the body as a garden. And gardens are comprised of tissue beds. And the way we determine which tissue bed needs tending is I ask the patient a question, and then when they tell me the answer, I actually listen. That's sort of the key part there. And that's sort of a lost art in and of itself. So if we're thinking that, we're thinking of these tissue beds in our body that need, to be restored to health, how does the body in nature heal itself? So let's just back up and talk about that. Well, blood vessels are ubiquitous. With just a couple of exceptions, there's blood vessels in virtually every tissue in the body. And these plasticized models, I love this image. If you've been to any of those, the Bodies exhibit or anything like that, the ones that I find really fascinating are these ones of the blood vessels because, they're everywhere. And so whenever you have an injury, it involves blood vessels. When you have an injury to a blood vessel, the contents of the blood vessel, blood, now finds itself outside of the blood vessel. That's the body's signal that something's wrong. Blood finds itself outside of a blood vessel. So blood is comprised of the serum, and then the cellular components are the white blood cells, the red blood cells, and the platelets. The platelets, when they find themselves outside of a blood vessel, they're really the whole signaling mechanism that something's gone wrong. They release a protein called platelet-derived growth factor. And platelet-derived growth factor is like the main signaling mechanism that there's been an injury. Now, surrounding these blood vessels are cells called pericytes. They wrap around the blood vessel. When pericytes constrict, you get vasoconstriction. When pericytes relax, you get vasodilatation. So when you have changes in blood pressure that are caused by narrowing of the blood vessels and widening of the blood vessels, vasoconstriction, vasodilatation, that is the action of pericytes. So a lot of drugs that impact your blood pressure exert their effect on the pericytes. When pericytes come into contact with this platelet-derived growth factor, when the platelets find themselves outside a blood vessel, they release platelet-derived growth factor, that comes into contact with the pericytes. The pericytes actually detach off of the blood vessel and morph into what's called a mesenchymal stem cell. Now, mesenchymal stem cells, if mesenchymal stem cells are Superman, then pericytes are Clark Kent, right? Mesenchymal stem cells have two superhuman powers. One of them is they have the ability to differentiate into target tissue cells. So a stem cell, what makes a stem cell is it has the ability to self-replicate, it has the ability to turn into a new version of itself, or it has the ability to turn into a target tissue cell. With MSCs, mesenchymal stem cells, they have the ability of turning into any of the musculoskeletal connective tissue cell types. They also, much more importantly, for the basis of this conversation, exert what's called a paracrine effect. Paracrine means intercellular communication. So they actually, these MSCs have the ability to recognize when they're in the presence of damaged tissue. When they are in the presence of damaged tissue, they release this whole cascade of growth factors that control inflammation, kill invading microbes, and trigger the growth of new connective tissue. Most importantly, new blood vessels. So if neovascularization is the growth of irregularly shaped abnormal blood vessels, angiogenesis is the growth of good, healthy blood vessels. So take, for instance, wound healing. So when you have some sort of ulcer on your skin, the way an ulcer heals is first you grow blood vessels, then you grow skin over top. So effectively, whenever we have healing after injury in any tissue in our body, it is a stem cell mediated event. That's how the body heals itself in nature. We have stem cells in virtually every tissue in our body, and their job is to maintain the health of their microenvironment. The problem is, as we go through life and put a lot of wear and tear on our body, have major trauma, have repetitive micro trauma, we can actually overwhelm the body's ability to heal itself after injury, and that's when you get degeneration. So let's move forward. So that's how the body heals itself naturally after injury. So how does that translate back to regenerative injection therapy, regenerative medicine? Well, it started with prolotherapy. So back when I was first treated in the 90s, it was with prolotherapy. And the doctor that I was talking to, who's the prolotherapist, is where there you are, great. Yeah, prolotherapy is the injection of a natural substance, which is generally like a dextrose. The most commonly used is like a 12.5% dextrose solution. There's other agents that are used, but it's whatever it is. It's a substance that is simultaneously nutritive and slightly irritating. So we're giving the body the nutrition that it needs, but we're also just like giving a hyper concentrated solution that causes just like a controlled, mild inflammation. What that does is it effectively tricks the body into thinking that it's endured a new injury without actually having caused any real tissue damage, thereby launching the body's natural ability to heal itself. So I practiced prolotherapy when I was still in naturopathic school in the 90s, and I was very fortunate to have done one of the very few hospital-based residencies for naturopathic doctors. It was in Derby, Connecticut. And when I was there, I mean, it was like a big deal that I was even allowed in the door, you know, as an ND. Like, it was pretty awesome that I was even allowed to be there. There was no way they were going to let me do prolotherapy on the residents, right? But I had to practice. I had taken it I'd taken some courses, and I needed to start doing it. So I found out about this organization, actually the Hemwall organization, the Hackett-Hemwall organization, and I contacted them, and they do this trip where they take a bunch of doctors to Honduras, and they basically get all these medically underserved people, and they line them up, and there's all these people who are living with pain, and they all show up together, and then they do a bunch of prolotherapy treatments. Well, I signed up to go, and they said, "Oh, I'm sorry, we don't take naturopaths. It's because in the Honduran law, this and that," and it was there were some answers there, none of them really made any sense to me. So I was sort of upset that I wasn't invited. So I decided that, you know what, here in the United States of America, there actually are poor people. I don't have to go to Central America to treat poor people. So I reached out to this. I found the largest homeless shelter in Bridgeport, Connecticut. And this was a 50-bed homeless shelter that was basically like a halfway house. And it was a Christian-run one, and so I knew that the state-run ones were like this mountain of red tape, but the Christian ones, they could do whatever they wanted. So I went in and I basically just knocked on the door and went in and introduced myself to the director, and I said, "Hi, I'm a naturopathic doctor. I'm a first-year resident. I do this therapy. It involves injections. It's for the treatment of chronic pain. I would like to practice on your residents." And as I was saying it, I was like, this must sound completely crazy. What is this lady going to think? And I just remember she looked at me and she said, "Okay, do you have your stuff? Can you start now?" And I said, "Yeah." And so anyway, my first 2 years of doing prolotherapy was on these guys, and it was fantastic. I loved working with these guys. I learned so much from them. They were it was just a fantastic experience. So prolotherapy is, it's very simple. It's done with just palpation, no imaging, and you sort of just, find the painful area, and your anatomy, and you inject what you believe to be the affected structures. And I did that for the first 4 years of my private practice, and it worked very well. I just found that, you had to do a lot of treatments. I mean, it was typical to do 6, 8, 10 treatments once a month for a period of, I'd see someone multiple times over a period of a year. It didn't work as well for really advanced cases, like the bone-on-bone and that sort of thing. Well, in 2006, one of my naturopathic colleagues found out about platelet-rich plasma, and this was sort of a brand new thing. And so the idea is, instead of injecting dextrose, you do a blood draw, put the blood in a centrifuge, concentrate down the platelets, and use that in your prolotherapy solution. You inject platelets. Now, as you remember, the cascade is first you have injury, then platelets come to the area. Platelets release these growth factors that trigger the stem cells to activate. So really, it's the same concept. We're just skipping a step. We're just, we're same injections. My mentor used to say, same sheet music, different instrument. So we're just taking the blood platelets and injecting those. So from 2006 to 2010, that became 100% of my practice. And what I found was now instead of 8, 10, 12 treatments spread out over a year, I was doing 4, 6 treatments spread out, like, each one every 2 months. I mean, really, like, I was able to do it in many fewer treatments. It just sort of seemed to me like anything prolotherapy could do, PRP could do better. We found that, because it was a little more involved, it sort of, it seemed reasonable that the injections should be a little more precise. So we started using ultrasound guidance. And that sort of became common practice, especially among the naturopaths doing prolotherapy and PRP, was to use ultrasound guidance, because you could actually see the needle. And that's kind of what just confused this computer, as I had a video in there of showing what ultrasound guidance looks like. So then in 2000, so then suddenly, like, my practice kind of bumped up a little bit in complexity, and but I was very happy with this, and I thought this was what I would do for the rest of my career, and didn't really think much else could. I thought we were at the pinnacle of where we could go with all of this. So then in 2010, this is a patient of mine who I had treated for years. Her name is Laura, and I'd had pretty good success with her with prolotherapy. Then we, but I just couldn't quite get her where she needed. And then we started doing platelet-rich plasma, and I still just couldn't quite get her where she needed to be. She had had a serious traumatic injury to her knee, a lot of degeneration, and we just couldn't quite get her there. So she shows up in my office, brainiac, stack of journals like this, puts them on my desk. It's all medical journals, the use of bone marrow-derived stem cells for the treatment of arthritis. It was all animal studies, because that's all there really was back in 2010. And she put it on my desk, and she said, "Harry, I want you to inject my bone marrow into my knee." And I said, "Laura, I don't know how." And she said, "So, learn." And I said, "Laura, I mean, I've heard of this. I know a guy in St. Louis who does this. You could go to him." And she said, "I don't want your friend to do it. I want you to do it." And I said, "Laura, I'm a naturopath. Like, we don't do that, Do you know how much criticism I would get if I started doing bone marrow aspirations?" And she goes, "Well, I'm an engineer for NASA, and I'm a woman. So if you'd like to complain about people saying you're out of your league, you're really talking to the wrong person here." And so I said, I really couldn't argue with that. So, I found a surgeon in Florida, Joe Purita, and he let, I sort of, at that time, there were like 10 people in the United States doing bone marrow stem cells. And I called the first 9, and like, they didn't just hang up on me. They like threw the phone across the room. Like, they were just like, so, and Joe was the 10th person I called, and he's like, "Yeah, sure, come on down. When do you want to come?" So I went down and watched him do a couple of procedures, and that was it. I came home and started doing it. And man, it worked so well. Like, I was, after, I'd been doing full-time prolotherapy for 4 years. Then I'd been doing full-time platelet-rich plasma for 4 years. And then I started doing this, and it was just like, now instead of 4 to 6 treatments, now I was doing like 2 treatments, and like the really advanced bone-on-bone cases. And not everybody. I mean, I had people who I didn't help. I still have people I don't help at all. But overall, like, the 80% of the people I was seeing were having these like remarkable outcomes. Bone marrow is, bone is comprised of the hard outer cortical bone and then the spongy medullary cavity, the spongy bone on the inside. And it's super rich with stem cells. But it's not only stem cells, it also, like, it's raw bone broth from your own body. I mean, it has all these other constituents in it that are like just chock full of stuff that are like your body's natural drugstore. I mean, this is all the stuff when we have injury, this is like the soup that is responsible for tissue healing. So I started doing ultrasound-guided bone marrow aspiration. So back then there was like nothing going on. There were no trainings. There was nothing in the literature. So this group, American Academy of Anti-Aging Medicine, put on this, they called it a fellowship, which is a very loose use of the term. But I went and did it. I was in the first class of stem cell medicine. And it was really interesting because there were probably like 60 people in the group. Half of them were Americans who were like me, like just trying to, well, actually, I was sort of, I'd done more cases than most, but like most, they were trying to figure out like how to do this because Like no one really knew how to do it yet. The other half were all Central and South Americans who'd been doing it for years. And I speak Spanish, so like I just immediately gravitated to these guys, and I'm like, hey, can I come visit? And they were like, yeah, sure. So I spent the better part of 2011, 12, and 13 every other month, because I just wanted to do stem cells. Like I wanted to be a stem cell guy. So I basically stopped doing prolotherapy, I stopped doing PRP, and so my practice was slow because no one had heard of it back then. Like you didn't like, it was like no, it wasn't happening yet. So I would do like 1 month at home, and then I'd do 1 month traveling to these other clinics. One of the people I visited was this Cecilio Bratt, who'd been doing bone marrow from what he had this very old clinic, like in the middle of nowhere in Venezuela, this tiny little town in the mountains. So if there was ever any like question as to my dedication to learning stem cell medicine, I went to Venezuela, and don't go to Venezuela. So I went and visited him, and he had this like this clinic was open from 8 in the morning till 8 at night. He had 2 staff rotations, like the morning and the afternoon, and then he would just work all day. And he would just like do stem cell treatment after stem cell treatment. It was these old style beds, almost like chiropractic, like the old school chiropractors that just had these beds separated by curtains. And he would just go from one to the other, putting needles in the sternum, aspirating bone marrow, putting it through an ozone machine, and then giving it IV. And he was the first one. He showed me he had an iPad, and he had like thousands of patient testimonials of like, imagine name the condition, and he's treated it with that. And I mean, it was amazing. So he charged pennies, and he treated like the Chavez family to the illiterate farmers and everybody in between. And I was just completely blown away. So then from there, I went to the Stem Cell Institute, which is still in existence and very famous. This is, in the Western Hemisphere, probably the premier stem cell institute. Neil Riordan is the founder, and he was a brilliant guy. I mean, it's this state-of-the-art, multi-million-dollar stem cell lab that grows every imaginable kind of stem cell, and they treat, you name it. They treat all sorts of things. Very expensive. So this was like the complete opposite end of the spectrum from Cecilio Bratt. And what I found was, the Stem Cell Institute got these like amazing outcomes. I mean, not with everybody, of course, but overall they were getting these incredible outcomes. But so did Dr. Bratt. I mean, he was getting good outcomes too. It was just different. So I started thinking about this whole idea of sort of cost, benefit, and risk. And there's sort of 3-dimensional graph of sort of like of this sweet spot. There had to be this sweet spot that would be right, not just for, it wouldn't be for everybody. I mean, that's the thing. Like, everybody's different, and different people want different things. And so I sort of was on this mission to find out what was right for me and the people that I wanted to help. So I just want to tell you, you guys will probably get a kick out of this story, but one of the people in my travels was Carolina Lucena, who's at the top of this picture. She comes from, her family is considered like a national treasure in Colombia. They're like this dynasty. Her great-great-grandfather performed the first cesarean section in Latin America. Her great-grandfather performed the first brain surgery in Latin America. Her grandfather performed, opened the first pharmacy and did free medical care for the poor. And her father, Dr. Elkin Lucena, did the second in the world, first in Latin America, in vitro fertilization. And he had an IVF lab in Bogota that she's a cellular biologist, and she ran the lab. And she kind of got burned out on that, and she got into stem cells with her brother, who's also an MD. And so I started traveling down, and I would take my patients who wanted culture expanded stem cells there. And then I would do some orthopedic ultrasound, because they had ultrasound, because it's a IVF clinic. So I would do ultrasound guided injection for their orthopedic patients. And I want to tell you guys this story, because it's not something I really get to share in scientific meetings. But I was out to lunch, and Bogota is very elegant, if you haven't been there. It's muy elegante. And I'm in this nice restaurant with Dr. Elkin, who is, or Dr. Lucena, who's, he's like the closest thing to royalty that I've ever encountered. I mean, he's comes from this medical dynasty, and he's just incredibly elegant. I mean, just oozes with elegance. And I'm at lunch with him and Carolina. And Carolina said, Harry, why is it that when she said, the way I can tell how happy stem cells are is how quickly they attach onto the Petri dish. That's the indicator of how like robust and happy they are. She said, when most doctors give me their samples, it usually takes a couple of days. But when I get yours, they attach in a couple of hours. Why is that? And I had no idea. I mean, I had no idea what to say, but I felt like under the circumstance, I had to really think about it and give an honest answer. So I sort of quieted my mind, and what popped into my mind was this experience that I'd had where I was about 3 years into doing stem cell therapy, and there's all these steps. Like it was much more complex than anything I'd ever done, and I really was looking to get into that flow state. I was trying to reproduce, what I'd experienced with rock climbing. So I remembered this procedure that I did for the first time I totally got in a flow state. Like, I didn't have to think about what I was doing. I didn't have to talk to my assistant. She didn't have to talk to me. The music was perfect. The light in the room everything was perfect. And it just everything flowed. And afterwards, I sat down with this woman that I'd just done the procedure on, and I said, I have to tell you, you just received the most perfect procedure I've ever performed, and maybe ever will. And she was completely unsurprised, and she said, at this moment, there's 30 people at my house praying for you to do a good job. And I just went, okay. So I remembered that, and I just said, Carolyn, the only thing I can think of is that when I operate, I clear my mind. I don't think about anything else. I don't think about what I'm going to have for lunch. I don't think about anything else except helping the person who's here in front of me. And Dr. Elkin, Lucena, who almost never speaks, he just sort of went, "Si, senor," and then he went on to tell me that the reason he's such a famous IVF doctor and why his outcomes are so superior to the national average is when he operates, he fills the room with love. He doesn't think about anything else. He completely clears his mind, and he thinks about helping the person right in front of him at that moment. So it was just a very nice experience that I had that it was a feel-good moment. I thought I'd tell you guys about that. So one of my friends that I worked with over those years when I was commuting to Central America and South America was Carlos Chiriboga in Guayaquil, Ecuador, who's a great friend. This guy he's an orthopedic surgeon and just a gentleman. And during those years, I would go to his hospital and I would harvest and prepare stem cells, and then I would hand them over to Carlos, and he would use them in traditional orthopedic surgeries. And this was one of the cases that we did. This was, at the time, it was an 11-year-old girl who was thrown from the back of a motorcycle, and her bone got infected. And so, it just disintegrated. And so this is no good, very bad. This is, this girl's probably going to lose her leg above the knee. So, very, very bad prognosis. So what Carlos did is he, kind of cleaned off the edges, put a bracket in, brought the bones close together, and every day stretched it 1 millimeter, but then once a week we would do bone marrow stem cell injections directly into the point of maximal growth. And it took, it was many months, it was almost a year of treating this little girl, but last I heard she was, out of high school and played soccer, in high school. And, wasn't the best player, but that's cool, She has her leg, and she's pretty happy about that. So if any of you don't know who this is Gary Young, Young Living Essential Oils, who just very tragically died just about 6 months ago, which was really awful for everybody. And especially him. But anyway, he was a wonderful guy. But he was another one who'd been a patient of mine for years, and I had treated him for years for his back pain, and I did pretty well with him, but I just could never help him with this like midline pain, worse bending forward. He just had the like, I could get his pain down to here, but it just never got better in his midline. And I was like, Gary, you need stem cells directed directly into your intervertebral discs. And he said, okay. And I said, well, yeah, I don't do that, but I have a friend in Texas who does that, and you have a private plane. Like, I'll go with you. He said, I don't want your friend to do it. I want you to do it. I just went, oh man. I said, here we go again. I said, Gary, like, in order to inject intervertebral discs, you have to do it with X-ray guidance, and like, I'm a naturopath. Like, I can't do that, And he's like, I said, Gary, do you know how much criticism I'll get? I mean, seriously, like, much more than aspirating bone marrow. Like, this is really storming the ivory tower. I mean, I will be called a quack. I mean, it will be awful. And he's like, have you Googled Gary Young lately? He's like, this guy built a $1.5 billion a year corporation with his bare hands. And he's like, if you want to complain to me about people calling you out of your league, like, you're definitely talking to the wrong person here. And I just went, oh. So, I couldn't argue with him. So I learned how to do X-ray guided injection. And the truth is, it's not that hard. It's actually a lot easier than you'd think it is. So just because I have this picture up there, I may as well just tell you, like, I do all my procedures under sedation. I have an anesthesiologist, puts everybody to sleep. So before anybody gets too grossed out about, like, how much this hurts, it doesn't hurt because you sleep through it. But the amazing thing about X-ray guided injection is now you can put stem cells anywhere, especially the intervertebral discs, epidurals. I mean, pretty much any moving part in the body, I can now put a needle and put stem cells there. And that's, the way this works is you have to get, you can do an IV of stem cells, and it's going to do some good, but really, for something like an intervertebral disc, there is no blood flow. There is no blood flow in a disc. So if you give something IV, it's not going to get there. You have to put it exactly where the problem is. You can also, now I'm able to do epidurals, which is like magic. You put bone marrow stem cells in the epidural space, and like magic occurs. Like I've been doing this type of stuff. I've been doing stem cells for 8 years. I've been doing the fluoroscopic guided for 6 years, and still to this day, I'm like, really? When I talk to people, how they're doing after. This is an injection into C1, C2. This is in your neck, the joint, the level that's responsible for rotating your head. When you have difficulty turning and checking your blind spot, that's this injection. So, so I've been talking about bone marrow stem cells, but the thing is, fat is incredibly rich in stem cells. I didn't start doing fat right away. I started doing it in about 2013. So essentially what you do is you do liposuction, a miniature liposuction, lipoaspiration. Then you put the fat through a process called enzymatic digestion, where you actually add a substance called collagenase and then put it through this whole process. And whereas from a bone marrow aspiration, we're going to get in the tens of thousands of stem cells, from a lipoaspiration, we're going to get in the tens of millions of stem cells. So this is what the process looks like. Is it gets incubated and then centrifuged and then incubated again. And in that picture, you can see up at the top there's the free fat, and then at the very bottom, that little pellet, that's the goods, that's the stem cells. So when I first started using the fat, my instinct was to combine the bone marrow with the fat. And I thought, here I've got this opportunity to compare them. Maybe one's better than the other. Maybe I don't have to do a bone marrow aspiration. And what I found was, as had been my experience, the people who got bone marrow kind got very consistently good results. The people who got the fat, but usually I'd have to do 2 treatments. People who got the fat, when it worked better than the bone marrow. But I had like a 30% non-responder rate. And I'm not exactly sure why that is. And I still don't know why that is. But then I started mixing the 2 together. And what I found is when I use bone marrow combined with fat stem cells, I get the consistency of the bone marrow and the augmented improvement, these like really amazing outcomes as the fat. So just in the last year, I've started using a couple other products. Now, there's a lot of people are starting to use umbilical cord stem cells. I don't really like to use umbilical cord stem cells, and the reason I don't like to use it is I don't really love the idea of putting somebody else's genetic material into my patient. It's probably safe, and I just don't like it. And probably is not, I don't really like it. But there is an umbilical cord product that I use, which is the Wharton's jelly. So this is without cells. This is the Wharton's jelly is the insulative layer of the umbilical cord. It's this gelatinous substance that is made up of bioidentical human-derived hyaluronic acid and chondroitin sulfate. So this is like the ground substance of joints, of discs. This is the matrix that is connective tissue. So what I like about using the Wharton's jelly is it gives the stem cells basically the building blocks that it needs to grow new connective tissue. The thing that's probably the most exciting thing to come along in regenerative medicine in the last couple of years is exosomes. So this is like so incredibly slick. Essentially what this Chimera Labs does is this is a lab in New Jersey, they recruit these women who are scheduled to undergo cesarean sections. They screen them for every imaginable communicable disease. If they pass that, then they give birth to the baby, and the lab takes possession of the placenta. They then take the stem cells from the placenta, culture expand them, so you grow hundreds of millions of them, and put them in a stressful culture medium. So you basically trick the stem cells into thinking that their host is under duress. So they sprout these vesicles filled with growth factors that are, in fact, the active ingredient of stem cells. When we're talking about that paracrine effect, where the stem cells are communicating, that is the currency, that's the active ingredient. Now, what makes my stem cells 50-year-old stem cells is as we age, we lose the ability to manufacture those very growth factors. So what I like about this is they take these placental stem cells, which are the most robust stem cell, force them to grow these exosomes. They then discard the stem cell, including the other person's genetic material, and just keep the exosomes, which are these little vesicles with just the growth factors, no genetic material. Now, the membrane of that exosome is identical to the membrane of my stem cells. So what we think from looking at the research of the use of exosomes in mostly kidney disease, what we think happens is when we add the exosomes to your own stem cells, that your own stem cells actually envelop them into themselves, thereby effectively making your own stem cells a younger person's stem cell. I've been very happy with using those, especially in my 65 and older crowd. Because what I find is when I treat young people, I mean, it's just so easy. But when I treat older people, my results drop off. I do great with some people, but then I have a higher non-responder rate the more the population ages. And since my experience so far has been when I use the exosomes in addition to someone's own stem cells, it seems to really make a person react to the treatment like a younger person. So the thing that's really, if you look at the mushrooming cloud of scientific data on stem cells, you name a condition and it is being studied with the use of stem cells. I only treat musculoskeletal pain. I'm in Northern California, so I figured I'd put an Alex Gray picture in there. So, I just treat musculoskeletal pain. That's all I do. I like to do one thing and be really good at it. There's, sort of two categories. There's peripheral joints, which is shoulders, elbows, wrists and hand, hips, knees, ankle, foot. And mostly what we end up treating is arthritis, because that's a common thing. I mean, that's just wear and tear of the joints. And that is, we tend to look at the x-rays a lot, but the truth is, if you look at the data, it doesn't, like how bad the x-ray looks, as I said earlier, like really does not predict how much pain the person is experiencing, doesn't predict how well they're going to respond to treatment. It's really just like you listen to you ask the person questions, you listen to the answers. But treating joints is rewarding, but I must say treating spine is really my passion. And I would say the reason for that is because if somebody has an arthritic knee and I keep them away from the surgeon, like that's great, and it's a wonderful thing. But worst case scenario, they can have a knee replacement and it's not the end of the world. But with the spine, there's no good options. Like when I get a 30-year-old with a severely dehydrated lumbar disc, man, there's nothing. Like there is nothing for that except narcotics. Like it's narcotics or nothing, because steroid epidurals don't help, and like you really can't fuse a 30-year-old, because now you're damning them to a lifetime of continual fusion. And if they live to be old enough, their entire spine will be fused. So this is a paper that I published on treating desiccated discs, dehydrated discs in mostly young people. And I mean, it's just phenomenal. Like I can't even believe it. I presented this paper at a meeting last weekend, and it was funny because I went on right after this guy who is, invasive radiologist, interventional radiologist, who is like credentialed up and down to the North Pole to the South Pole, like doing, and what he's doing is he's taking like he's getting organ donors and taking like cadaver discs and chopping them up and then taking the stem cells out of this cadaver's vertebral bodies, and it's all hospital. It's like the opposite extreme of what I'm doing. And if you put our charts next to each other, it's almost identical, the outcomes we're getting. I mean, it was so weird for us to look at each other. We were kind of like, I'm this like poodle and he's this pit bull, and we're kind of looking at each other, and we're like, it's staggering that we're getting the same outcomes, even though we're at such opposite ends of the spectrum philosophically and from a pedigree perspective. Something that I've started doing in the last couple of years, a lot of my patients are farmers and ranchers and oil field workers. I just have, I get those guys, and these are people who have arthritis throughout their entire bodies. And literally, I mean, they're like riddled with arthritis. And because I work with an anesthesiologist, and because I've never billed insurance, so I've never been brainwashed into thinking that you can only treat one area at a single time, I do a lot of these. I've gotten a reputation as this guy who does like big treatments. So I'll do like in a single sitting just about someone's entire body, and I sort of affectionately named it the full body stem cell makeover. Well, when I started getting guys like Dave in, when I started getting Ben Greenfield, when I started getting these, these biohackers in, I thought, I wonder if people would be interested in this. And so I started offering it, and I can't believe how many people, they're like, yeah, I want that. And so what we do with full body stem cell makeovers, we take a large volume of bone marrow, we take a large volume of fat, we isolate the stem cells, we concentrate the stem cells, we put a ton of exosomes in there, and then we literally, over the next 2 hours, inject the entire body. The spine from the base of the skull down to the tailbone, both sides, flip them over, both shoulders, both elbows, both wrists and hands, both hips, both knees, both ankles, feet. I had a little video of Ben Greenfield talking about his experience, but because of the technical stuff, I decided to delete it. So it's something that we're doing more and more of, and I figure that Silicon Valley Health Institute, you guys probably would be interested to know about it. So this is my other car. This is the pilot fish. And there was a time in my life when having a 40-foot long, 8,000-pound fish made of steel that I'd drive at Burning Man, there was a time when that was like the proudest achievement of my life. And I used to finish talks with pictures of the of the pilot fish. But then I had these little meatballs that are, are kind of a late addition for this sort of late starter. And they might just look like normal kids to you, but that's pretty much what they look like all the time to me. So anyway, thank you very much. It's really a pleasure to speak to you guys. Questions now?
Yeah, questions. So who, are we on? Yeah. So who would like to ask a question? Right here.
You mentioned that you and this other doc that was sort of the Ferrari guy, or whatever. What would the difference in cost be between the two treatments?
Oh, do you mean the radiologist? Well, his is all done it's research. So you might get placebo. It's a double-blind placebo. So it's free unless you get placebo, and then it's a bummer. So
you were saying the two charts were the same output. I mean, the same outcomes.
Oh yeah. Well, just talking about the study that he is, the very formal scientific study that he's doing, and my goofy little survey that I was doing. So yeah, it's not private. It's it's a study.
What was his name?
Beal, Doug Beal.
I was just wondering if you always inject into muscular tissue or joints, and if you ever it goes through the bloodstream, the stem cells, and kind of another question has to do with autoimmune conditions. If you always treat the site that's having pain versus kind of the immune system, and so how do you get to something that makes a whole body system?
Sure. So we just treat musculoskeletal pain. So because of that, we're really focused on the treatment of whatever structure is involved. There are clinics that do systemic treatments. They are very much in the crosshairs of the FDA, and I really, because of I just want to keep on doing what I do because I think I'm good at it. I really just focus on what I'm good at, which is treating musculoskeletal pain. But there are plenty of clinics in the United States currently that are doing systemic treatments.
What kind of results are they getting? Is it still
I think quite good. I mean, I think for all sorts of things, for neurologic conditions, for autoimmune. I mean, in the scientific literature, autoimmune disease is a major indication for stem cell therapy, intravenous stem cell therapy, which I don't treat, but I mean, it is a major indication.
So,
yeah, whoever's got the microphone.
what if you squirt this stuff into the brain?
I'm sorry?
What if you squirt this stuff into the brain?
Yeah, so there's the thing about exosomes is so the trick about getting stuff into the blood-brain barrier is getting them into the brain that way. So the nice thing about exosomes is exosomes are small enough to freely cross the blood-brain barrier. Now, as far as stem cells, there's either you can give it intravenously or intraarterially, and what you do is you preload with a medication called mannitol, and mannitol is a very large sugar that's used in emergency medicine that temporarily, it's a diuretic also, but it temporarily renders permeable the blood-brain barrier. So you can give mannitol intravenously and then follow that with intravenous stem cells, or there are clinics that will do intrathecal injections, which is basically like a spinal. And then the other way is there is a guy in Beverly Hills whose name is, it's going to come to me in a second. I'll remember his name in a moment, but he's actually putting in what's called an Ommaya reservoir, which is a port in the skull. He just drills a hole in the skull and then puts a little port there so he can inject directly into the brain. And he's treating dementia.
Okay, so we'll do over here, and then I'll come back over there.
I recently had received advertisements and videos on stem cell therapy that's now legal in Texas. Mm-hmm. And they had a series of like 9 or 10, or they wanted you to watch them in series, okay? And I got 2 things like that were advertised on YouTube and such as that. Are you familiar with that and what's going on down in Texas?
Well, Texas is the only state that actually has a law saying that stem cell therapy is legal, which is good, but it's also bad because then there's a lot, then they have very strict criteria. It has to be done in a hospital or a surgical center. It has to be done, there's actually like, it's in a way they're more limited. In the rest of the states, the rest of us are just kind of saying, look, this is up to the medical boards. This is not up to the federal government. So we're just going to keep doing what we're doing until told otherwise. Now there are the problem with fat-derived stem cells is the FDA has just recently in the last year had the Department of Justice sue the two leading adipose-derived stem cell clinics in the United States, one on the East Coast, one on the West Coast. So we might lose adipose-derived stem cells depending on how that trial turns out. There's a chance that we could lose adipose-derived stem cells, in which case I'll just switch back to bone marrow and exosomes.
Okay, now over here.
And the reason why the case has been brought?
Well,
what's the problem?
There's what they say is the problem, and then there's what we think is the problem. And I hate to sound cynical, but we think that stem cell therapy, especially intravenous, because the thing about adipose-derived stem cells is you get a huge number of them, and they can be delivered intravenously. So now you're like directly competing with Big Pharma, who has stem cell products currently in the pipeline.
Sure.
So and the argument that the Cell Surgical Network is making, and that the proponents of adipose-derived stem cells is, hey, this is a medical procedure. Like, this is not a drug. I do a liposuction.
Right.
I isolate the stem cells. How is that a drug? That in no way resembles a drug.
Right.
But that's the argument they're making, is that it is in fact a drug and a non-FDA approved drug.
So briefly, why is the body putting the cells into the adipose tissue? And then along with that, is there any limit to the number of times you can do a procedure based on somehow using them up?
Mm-hmm. Yeah, so
how do you think about that over time?
Well, the reason it's in adipose is just because the adipose is highly vascularized, and mesenchymal stem cells come from pericytes. So wherever there are blood vessels, there are pericytes, and pericytes are what become MSCs. So that's as much as we know. There's no real upper limit that I'm aware of. I mean, I stopped bringing patients to Bogota, Colombia, because to culture expand their cells, because I found that really for the treatment of musculoskeletal pain, which is what I do, we do 1 or 2 treatments and we're usually done. And then I might hear from them again 5 years later. But this isn't something you'd want to like. Now, if you have if you have like Parkinson's or MS or something like that, that's a different story. Then you really do want to be treated like once a month or once every other month for the rest of your life. And then you want to use either culture expanded umbilical cells or your own culture expanded, and that's where you need to go abroad currently to do that.
Thank you.
Next, okay. You had your hand up next.
You don't mean go abroad once a month, do you?
Well, theoretically,
Maybe.
yeah.
Okay.
I mean, to do it legally, yeah.
That's not my real question, but that just came up right there. But my question is about the arthritis. Are you talking RA or are you talking osteo?
Osteoarthritis, yeah, because RA is a systemic disease.
What about osteopenia and osteoporosis?
Yeah, those are systemic diseases that I don't really treat. And I'm not really aware of using stem cells to treat osteoporosis. There might be people studying that, but I'm just not aware of it.
I just wonder why, because that seems so widespread and so
well, I think
epidemic.
Osteoporosis is really like a childhood disease. It's something that you don't build enough bone density early in life, so you like deplete your reserves as you get older, and then you do stuff. Then there's other things we do with lifestyle to accelerate that depletion. But I don't know that stem cells would really reverse that.
It just seems like it would, but yeah, I've heard that before.
I was wondering how it's used for, say, a vertebra that has deteriorated, has crushed or collapsed, and spinal stenosis?
Sure. So let me answer spinal stenosis first. So
Okay.
spinal stenosis is, you have the spinal cord and then the tunnel through
Yes.
which the spinal cord travels is the spinal canal.
Yes.
And spinal stenosis is the narrowing of that canal.
Yes.
And it usually is caused by thickening of the ligaments. It can be from a herniated disc, but it frequently is just the ligaments that travel along the length of the spinal canal thicken and then over time actually ossify. They become like an
Okay.
annular bone spur. It's like a circular bone spur.
Okay.
And so that is really a hypoxic condition. That's from lack of you lose blood flow and then you get that ossification.
Okay.
So I treat a lot of spinal stenosis, and I don't know for sure why it works, but it seems to work. And the reason I think it works is because of this angiogenesis, where we're growing healthy new blood vessels that can kind of reverse that ossification, that circular bone spur.
Okay.
As far as the deterioration, a crush fracture would be difficult to treat. If it's really like the vertebral body's completely smashed down, probably somebody wants to talk to a surgeon. But sort of, generic degenerative disc disease, we do quite well with that.
Good. Good. Thank you.
Let's see, let's go here.
In older patients that have less stem cells, have you? In older patients that have lower stem cells, have you combined things like CB2 agonists to increase their amount of stem cells so that it will make your treatment work better?
I don't, and that's because I don't really want, I want to sneak up on the stem cells. Like, I don't want to do anything that's going to there's all sorts of strategies to increase the number of circulating stem cells, to like mobilize your stem cells. And I don't really want to do that. I want to sneak up and surprise them. When I put that needle in the bone, like I want to catch them sleeping. I want them to be in the bone marrow when I take it out. Also, I sort of don't want to get too cute also. Like I like keeping it kind of simple, just because that suits my personality. I don't really throw a lot of stuff. It's, that was always what with Dave Asprey, it would always come back to that. He'd be like, well, what about blah? And I'm like, yeah, I don't know. I'm happy doing what I'm doing. Like, I don't want to I tend not to get too cute. That's the best.
Even in older patients that have lower stem cell
Well,
counts?
then I like to add the exosomes. I like to use their own because they still have them. They have a decreased number and decreased function, but then I like to throw in those exosomes because I think it really does, sort of revitalize their own stem cells.
Thank you.
Sure.
Hi. What is the approximate cost for therapy of the degenerated disc? For the low back?
So you mean at my place? So for real simple treatments, it's starts at about $8,000. For moderate, it's around $15,000 for spine sorts of things. It can go up from there. It really just sort of depends on how many things we're injecting, and then if we're adding a bunch of exosomes and stuff. My costs are pretty comparable nationally, except the difference is usually like when you look at a lot of the other people, it's about the same price, but there it's just bone marrow, or it's just adipose, or it's just umbilical cord. So my price is about like those guys, except you're getting all three types.
Where do you get the exosomes?
Chimera Labs,
Oh, okay.
which is based out of New Jersey. The medical director is a guy named Doug Spiel, who's a crazy man and a great guy.
Okay, thank you.
So we've got a lot of questions here, but I think we'll take a couple more, and then those of you can, as we go on a break a little bit later, you can go ahead and come on, go down and talk with them individually. So let's go back here.
Hi. On the full body stem or the full stem cell makeover, How many people have you done it on, and what did they report?
Well, there's people who, okay, so I've done a bunch as far
Over
as
100 or
oh, yeah,
1,000?
Hundreds
Wow.
of the ranchers and farmers and oil field workers who it wasn't like necessarily like packaged as that. As far as like the anti-aging people who are just doing it, you know, yeah, the biohackers, oh, probably, you know, 20, 30, and they love it. I mean, one of the early ones was Ben Greenfield, and he loved it. Like he's like, I mean, I'm getting ready to come out with another little video of him on my YouTube page, but he's like, he feels like he's on fire. Now he's doing a bunch of different stuff, but I mean, he really credits that to, he does those, you know, those endurance races and wins. And, you know, he says he's like recovering crazy fast as a result, so.
I was wondering if you inject directly into the disc, does it damage the disc itself? Does it leave a hole or anything?
I don't think so, no. I mean, there is, you know, the detractors of injecting discs say, well, if you look at the data of people who've had provocative discography, that, you know, it actually causes permanent damage. Well, I don't think that's a good analogy, because when you do a discogram, you're putting a big needle in there and you're like shoving a bunch of air in there. You're like really blowing it up as much as you can. And this is like 1 cc of fluid. You know, it's just a very different animal. And these are people who already have damaged discs. Now, when I do the full body makeover, the anti-aging stuff, we don't inject discs. I only inject a disc if it really is diseased and very painful. So these are people whose like lives are miserable because of pain, and we inject them and they get better. So theoretically, 10 years, I mean, like, we don't know. I've only been doing it for 6 years, so I don't, beyond 6 years, I don't know, but there's people I've injected 6 years ago who are still doing great. So, and those people, 100% of them will say they're glad they did it. So.
Okay, so like I said, if you have more questions, please come down and talk with Dr. Adelson in person, and let's please thank Dr. Adelson one more time.